social communication really is an area that I think is very exciting and something very near and dear to my heart. Of course, we know that there are, social communication is a very, very broad area, ranging from nonverbal social communication, developing gestures, to social language, pragmatics, interaction, turn-taking, peer engagement. It's very, very broad. But I thought for today's talk that I would stay along the lines of some of the research that was presented earlier and give a little bit more detail on how we think about, in ECPHP, how we think about intervening on nonverbal social communication in two areas of nonverbal social communication: joint attention and requesting. So, as Amanda had mentioned earlier, joint attention, when you think about it non-verbally, really is about gestures to communicate about a shared activity or experience. Gestures like shared looks, where a child shifts their gaze from an object to a person, back down to the object, very excited about that attention shift to share their experience about that toy, that event, that activity, pointing to share interest, showing items to share interest. And really, it's not about obtaining help or obtaining a desired item. It's about sharing engagement and sharing interest. Requesting, which really is a function of communication where children communicate with other people in order to gain an item or to get help. Two very important areas of communication. We know that joint attention is significantly impaired in young children with autism. Requesting, for a long time, was thought that it was not that impaired. And as we study it more, we realize that actually requesting is impaired, but not to the same degree as joint attention is. The reason that I wanted to focus on both of them is that what we found through our research and in our everyday intervention in ECPHP is that using requesting is a very powerful way to facilitate nonverbal gestures, nonverbal joint attention. So it's a wonderful scaffold to develop not only an important function of communication, which is requesting in itself, but then also moving on to joint attention. We also know that joint attention is a very important area to develop early on. It's one of the very earliest ways that we can target social communication and make significant changes later on in language, in social outcomes. So thinking about effective ways to develop nonverbal social communication, as I said, is something we spend a lot of time on. The next question is, well, how do we go about doing this? And in the past, treatment in terms of philosophy has been very polarized. Providers in the past have tended to ascribe to one treatment approach, depending on their philosophical orientation. So in the past, providers have either ascribed to more of a developmental approach or a behavioral approach. And really, there wasn't a middle ground in terms of we could combine developmental and behavioral approaches and still achieve very effective outcomes. They tended to be very much a one-fits-all approach, and it depends on what the particular clinician's philosophy was. So in terms of a developmental model, the thinking is that children on the autism spectrum will learn best in a child-directed approach where the child drives their learning, their curiosity about the environment. The adult follows the child's lead, builds on their interest, builds on their learning, expands on it, and really uses natural teaching opportunities to do this. So it has a very natural look and a very child-directed feel. The behavioral model, in contrast, tends to be very adult-directed. The adult chooses the topic or the content that is going to be focused on. It's a very individualized curriculum with larger goals, then broken down into smaller skills that are taught in component parts. So the instruction is very systematic, focusing one skill at a time, building up towards that larger goal. We know that it involves repeated practice, and we also know that in the behavioral model, we use a lot of systematic prompting, and we use prompt hierarchies ranging from full physical prompting to partial physical prompting, verbal prompting, to independence, with many different types of prompts in between. But that's sort of the general hierarchy. And it incorporates principles of operant conditioning, reinforcement, for example, like you saw earlier in the PRT talk. I'm really of the belief, and I think that in general it's exciting that intervention is moving away from a one philosophy approach. And we believe very strongly in ECPHP that one really does not need to ascribe to one approach. Why not use the strengths of different approaches to achieve an effective outcome? And when we begin to think about where should we start, I think it's very important when we're targeting treatment, particularly, in all areas of development, but if we think even more particularly or specifically in the area of core deficits, we're thinking about developing nonverbal requesting in a child or nonverbal joint attention. The big question is, where do we start? And I think it's very important to take a developmental aspect to deciding on initial goals. So in some research that mapped onto some of the research Amanda was talking about earlier, some of the studies that Amanda was talking about earlier, we looked at when do nonverbal skills develop in young children without intervention. So if we don't intervene and we just look at, when do skills come in? If we look at typically developing children, typical children develop nonverbal requesting skills under 20 months of expressive language age. So they develop reaches, we see them giving, we see them pointing to request, all by 20 months expressive language age. Children with autism, in contrast, do develop reaching, and they do give to get help or to get items by 20 months of age, language age. But pointing comes in later, a little bit later, over 20 months expressive language age. If we look at joint attention, we see even more differences. So in typical children, coordinated joint looking, showing, following another person's gaze, following another person's points, and pointing to share about their experiences or their interests, all come in around under 20 months of age, expressive language age. With children with autism, we see a different picture. So they develop coordinated joint looks early on, and they follow points early on. But actually pointing to share for interest comes in later, over 20 months of age, as does showing. And in terms of following another person's gaze, that comes even later, over 46 months expressive language age. So, I look at this and I think it's interesting because, first of all, particularly in terms of joint attention, the children with autism are not developing skills in the same sequence that typically developing children are. So that's informing my treatment to start off with. That is, maybe I don't want to target skills in the same sequence that we do for typical development. Might want to be thinking in a different order. Why? Because possibly if the skills are coming in a different order naturally, maybe we can target them quicker. With intervention, we can possibly achieve a much faster change if we target them in the order that they might come in naturally for children with autism. So that's the first thing I'm really thinking about. The other thing I'm thinking about is, I might want to consider expressive language age and what might be developmentally appropriate for a child with autism when I'm targeting a skill. That piece I'm not I don't let that drive, particularly when I'm going to target something. If a child is ready and has all the other skills in that sequence, I'm going to go ahead and teach the next one. But if it's coming in slower than I expect, I might stop and think about what is that child's expressive language age, and could that be playing into why a skill is coming in a little bit slower. So really thinking developmentally and thinking about what we know about the development of young children with autism, in which skills I'm going to target, and potentially also when. So then again, why not take a combined approach to teaching joint attention? And Amanda touched on this earlier when she talked about the randomized controlled treatment trial, where we targeted joint attention and symbolic play in young children with autism. And in that approach, we used a combined approach. We used some behavioral strategies. We also used some developmental strategies. And so that study has been reported on a fair amount, but I think the specifics of how the intervention was delivered have not been described that well. It's important to note that actually we used a combined approach, using strengths of both behavioral and developmental approaches. We saw increased joint attention gestures as a result of that intervention. And then in the second paper, the changes early on in joint attention were associated with language gains later on. So the strategy of using a combined approach has been empirically validated through the research. Given that, and also through anecdotal evidence that we see every day, we use a combined approach in ECPHP to develop nonverbal social communication in young children with autism. And we use it in different ways. Children with autism are different, as you know. They are very individual, and there's a very broad range of how children respond and present. So for some children, we might use mostly behavioral strategies. For some children, we may use mostly developmental strategies. For other children, we may use a very mixed approach. And so it's highly individualized in terms of how much of any approach we can use. And I put that out there because I think that it's important to start thinking about using combined approaches in a flexible way to deliver highly individualized treatment depending on what is effective for any one particular child. In the research we used in the randomized control trial, we used behavioral strategies in a very adult-directed way in the beginning, priming the child for the skills that we wanted to teach, and then combined it with child-directed practice on the floor. So in that research, that was more or less the model that we used. Behavioral strategy first, and then more developmental strategies. So again, we used adult-directed priming in a contrived setting, so typically at a tabletop. We taught using behavioral strategies like errorless learning for skills and acquisition. So when we're teaching a child initially to point for to request or to point for joint attention, we're teaching them over and over again. And we were using direct physical prompting or verbal prompting or whatever level of prompt the child needed to ensure that they made no mistakes and that actually they used the skill in the way that we wanted. We used the prompt hierarchy to shape the skills. We did reinforce, although in a fairly natural way. We gave the child repeated practice. We incorporated the principles of generalization, so not only showing the skill with one adult, but with different people in different settings, with different materials. And we worked very much on success of smaller goals towards a larger goal. We also used developmental strategies on the floor, so that was a much more natural setting. We followed the child's focus of attention and interest. We modeled gestures, so if we were teaching a child how to point to share attention, we modeled it, and we did a lot of that. We provided language that was contingent on the child's attention. So if a child was focused on a toy, we labeled that toy. We didn't try to shift the child from what they were focused on to what we were interested in. Very important developmental principle is to stay contingent on the child's focus of attention. One of the reasons for this is that children with autism have a lot of difficulty shifting attention. And so if we really want to facilitate social interaction and language learning, we want to stay contingent on the child's focus. We also matched the language, our language, with the child's language development. So if a child's talking at the one-word stage, we want to keep our language to one word. If the child's combining two words, our language was two words. And then we reinforced naturally, so in a very, very naturalistic way. So I wanted to show you a few videos. A few of them are from the original intervention, and a few of them are children currently in the ECPHP. They're very short clips. I wanted to show you a little bit of what a combined approach looks like.
Jared, eat. Bigger. More. Bigger. Eat.
So here it looks a little bit more adult-directed, a little bit more behavioral. He's sitting in his chair. You can see he's in a little cubby. They're face-to-face. She provides the stimulus for him, which is the choice. But then he goes ahead and he chooses. And you can see he's very independent at this point. But she provides contingent language. She provides it at the one-word level for him. Eat. He's actually 3 years of age. He's around 12 months expressive language age. So the language is at the one-word level. Very simple for him. But again, it looks very natural. Here you see, and I wanted to show you that clip, because you can see how she waits. So again, it's adult-directed, but she waits, and he actually uses another sign, which is the sign for more. And she's very contingent and highly responsive to his sign, and very natural in her reinforcement and her language. So to me, this is a very combined approach. Looks fairly adult-directed, but when you start to break down the elements, it has many developmental elements in it as well.
Yes! Woo!
So now you can see this little guy. He's also around 3 years of age. His expressive language is around 17 months. Now he's independently pointing to make that request. You can see she's on the floor. A lot of reinforcement, very excited, providing the contingent language again.
Hello. Open. Open.
He decided he wanted to go for a walk, completely his choice. He went to find his backpack. They got it on. The choice was, the decision to go for a walk was his choice completely. He got to the door, and he had to make that request. And at that point, she's there completely focused on his direction, his choice, and what he needs. But she's there to provide the prompting and the modeling that he needs to get it done. In that case, you see she provides a model of a point for him. He models, he follows her model, makes the point. We're not requiring eye contact at this point. So you could see he was required to make the point. The reward, the reinforcement is very natural. They get to open the door, exactly what he wants.
Bear. Bear.
So here we move more towards joint attention, and I call this more pointing for self. So you can see now she's looking at a book. She's chosen to do that. She's sitting down. Now we really want to teach her that You can use your point for more social reasons. You can use it to share. But she really doesn't have any idea of how to do that. So the first thing that we do is we start to teach her, you can point to items purely to share interest. She's not making eye contact. She's really not that aware of her therapist. But her therapist is there providing what we call supported joint attention. And that is really teaching her the very beginnings of how to point to share. So she's having to provide a full physical prompt at this point to have her do that. She provides the contingent language. Bear. Child's highly motivated because she's interested in the book and she's interested in the content. She uses one word level again. That's the child's level of language. And we will further shape this little girl to do that more independently and then incorporate eye contact so that you have that full coordinated joint look shifting from the book up to the adult, back down to the book again. One more slide, one more video.
Where's your car, Jonathan? Here he is. Let me see.
So they're showing, and he's still requiring a verbal prompt because he wasn't doing it on his own. So she's saying, where's your car? And it's what we would call a general verbal prompt. She's not saying, did she say show me? Yeah. She did. Okay, she started off, where's your car? And then show me. And he does it, and he does it beautifully, but he's still requiring that verbal prompt to get it done. And if she needed to do more, she would have prompted more fully. But look how developmental that looks on the floor. He's engaged with what he's interested in. Very contingent, very natural. In closing, clinical considerations. The behavioral strengths that you're seeing, we're engaged in direct shaping of skills through prompting. There's dense practice. We do it over and over again. And I think that the behavioral approach has a lot of strength in that it really accounts for learning difficulties. It takes small skills, builds component parts, and builds towards a larger goal in a very structured, systematic way with very observable outcomes. The developmental strengths provide a lot of opportunity for ideation. We really want children to come up with ideas on their own and initiate. Big strength in contrast to the behavioral model, which is very adult-driven. It allows for child initiation. One big area of impairment for young children with autism, the ability to initiate. Developmental model gives them a lot of room to initiate and to do that more frequently and to become more practiced at it and to become more comfortable. It accounts for attention difficulties because we really are working with providing contingent language and building on children's experiences very contingently, which is shown to be very effective. So why adhere to one treatment philosophy? Why only think about ascribing to one philosophical approach? Why not incorporate different treatment philosophies and draw on their strengths? So I would argue, really, in terms of best practice, one size doesn't fit all. One treatment approach does not fit all. Let's combine different approaches in a flexible, creative way to meet each child's needs. I want to say thank you to the families and the children who participated in the videos. Thank you.